I be able to introduce Johnny. He's the Chief Medical Officer at San Mateo Medical Center and serves as the County of San Mateo leadership team. He also works for those who are trainees and residents on the call at SF General as a pediatric hospitalist. So if you're on call with him, you need to ask him for a few of his talks. He also cares for pediatric outpatients in Fair Oaks Health Center in Redwood City, and has done work with MSF as well as on Saipan. So today we're going to get to hear about his career journey. Thanks so much for joining us.
All right, fantastic. Nice to see everybody. Knowing time-wise, you might not have the time for, I love to know my audience who's here and your particular interests as I go through the talk about my journey. Maybe by show of hands, that might be the quicker way using the hand raising feature. How many here are UCSF peds, UCSF or Children's Hospital Oakland residents? Okay, you got one hand, you got the virtual hands, the real hands. Okay, all right. And then, yeah, thank you for those of you who have your camera on, at least the beginning, so I can see faces who I'm speaking to if you want to turn your cameras on for a second to see each other. And then how many others are people attached to UCSF in whatever way, either current, alum, or soon-to-be students? Let me see a show of hands of those who are UCSF connected. Right, got one, got a couple others, okay. And then, great. And then people who are in medicine broadly, anywhere else in the world connected. Okay, got someone there, Gaspar, Maria, okay. We got a variety of people all around, and then others who have heard about it. I know we have, and then pre-meds, or people who are thinking of entering into medicine at some point. At least we have a couple there. Fantastic. Great. All right. So I probably packed in way too many slides for this talk, but so it will be rapid fire. So you will be definitely engaged. And maybe, Teresa, I will ask for either yourself or Tiffany, give me like a 10-minute notice toward the end. So if we're not at the place where we get to ask questions by then you'll have the chance to be able to do so.
I'm gonna go.
No problem. And I can also keep track of the chat for you.
Yeah, fantastic. All right, great. All right. So with that, let me go ahead and share my screen. So here's a technical question from others. Go into presentation mode first and then share my slides, or go to share and then go into presentation mode? Any thoughts on how to do sequencing?
I usually do presentation mode and then share.
Yeah.
But then also you don't want the
global health residents, you will be able to go deeper with me for these two presentations that I give, and they are sequentially big chunks of my global health career. So one of them is the year that I spent as a Doctor Without Borders. And the reason I title it that way is it is a year because there are many different ways of working with Doctors Without Borders, and it's just my particular experience. I do love the catch phrase at the top, Médecins Sans Frontières, as the rest of the world knows it, except us who are arrogant and can only say things in English. The French organization, Doctors Without Borders, their motto is put your ideals into practice. And that is a lot of what the work is there. So my titles here and the roles that I have, and then the other talk I give is about the next 2.5 years that I spent in a small little speck in the ocean called Saipan. And that work was work that was also quite unique in its own. And I'll talk a little bit about each of those. And I won't go into any of the actual clinical cases for both of those, just with our interest of time today. It is a lot more about how do you go from having this vision or an ideal of what you want to be with your life, and then choose for yourself what works. So I will give you a model that worked for me, or that I've been able to reconstruct looking back about how I chose what I did. What I call my own personal fellowship, which is essentially instead of 3 years of one fellowship, I did 3 jobs in 3 years that gave me the full spectrum of skill sets that I was looking for. The shifting tides of life, and that is also apt for this particular slide of a beach where there's lots of tides shifting. Cases only if we have time, but I think mostly I'm going to allow us to have time for Q&A. So one way that I've been able to construct this, and I love getting feedback from people about how they've thought about things, is knowing each of us has our own journey and our own path. One of the key things to know, I finished residency at UCSF now 15 years ago. Global health fellowships weren't really a thing, or if they were just emerging. And for financial reasons, you basically spend half of your time where you actually wanted to be doing work internationally, and the other half you were a hospitalist or covering bone marrow transplant or whatever it is that they could pay for your fellowship. It had actually nothing to do with your career. Things have evolved quite a bit, and it'll be one of the last sections is one of the programs I'm really excited about that we have at UCSF that I continue to be involved in called the HEAL Initiative. And you guys may be hearing about it with one of the other lecture series, depending on who's on, but I'll talk a little bit about that one. One of the ways I thought about it as I was finishing residency is in the same way that people decide if they want to do a subspecialty is what skills do I want to gain and what lifestyle do I want? And so in the same way, as an example, if you want to be a gastroenterologist, skills, you're probably going to want to do endoscopy. You're going to want to be a master of the GI system at large, right? Liver, intestines, et cetera. And then in terms of where you would want to work, organization types, you would probably be at an academic center if you did that, or potentially private practice. So in that same way, I was creating for myself, what are the skills that I would want to gain if I want to work abroad? And so a lot of it was actually things that you don't always think about. So for me, it was going to be ethics, end of life ethics. So knowing here in academic centers, you have the luxury of child life, knowing that when you're abroad, you won't have that. So you'll be having end of life discussions potentially very rapidly and a lot more often. Being comfortable being in places that you don't speak the primary language, don't know the culture well. And so understanding yourself and what do you need to be exposed in that way to allow yourself to know that that's something that's comfortable for you. One of the other pieces is leadership. When you are abroad, there is this immediate assumption as the person who's coming with other skill sets and from another place that there's a deference that happens to you. How do you deal with that deference? How do you re-empower the people that you're working with? And how do you use the broad range of skills and power that you do have? And then organization types. I knew I wanted to start with a well-established large organization that I could learn from, and then move into a place where I was going to be sort of a bigger fish in a smaller pond. The other piece about lifestyle, just knowing yourself. Do you need to pay off loans right away? Are you okay to defer? Are you okay having less of an income for some period of time? Weather. Some places are super hot. Some places are going to be arid. Just being honest to yourself. What type of environments, what type of places do you want to be in? What type of cultures do you want to be around, or cultures that you're not comfortable with? And then one of the big ones that doesn't get discussed a lot is family. Do you have a partner? Do you want to have kids? Do you have an aging parent that you think you might have to come back to take care of? Some of these things get left off when we're just in your early 20s and just thinking of yourself and your own pathway, being honest about what those things look like. So no one thing will fit everything perfectly. And so one of the phrases that I've heard and kind of come up with and use is being a strategic opportunist. So just like a opportunistic infection that waits in line for the right conditions to spread, knowing that being open to something that is out there might meet 4 of your 6 check boxes, and it might give up 2 of the ones that you thought was most important, but actually would work out really well at that point. Being open to that and thinking through it. And I'll get into some of the specifics that I did. So the other model kind of layer on top of that is something called Ikigai. Has anyone here heard of Ikigai before? Okay. So it is a Japanese phrase, and it's 2 words. So Iki means life, and Gai means value or worth. So essentially your meaning in life, your life value. And one of the key things is that at any point in life, these things may shift. What's really important to you in your particular values. So as an example, my first job right out of residency, I was a neonatal hospitalist. So I worked in 3 different NICUs, neonatal ICUs and newborn delivery. So it was something that definitely had the green part. I It was actually the highest I was paid for the next 7 years of my life. Well, I guess including residency up to that point, every point, that point. It was something that was useful, what the world needed. It wasn't quite doing the global health work, so it wasn't quite what I love. And it wasn't allowing me to have all the skill set pieces that I could put into use that I was really good at, but it had some of those key things that were there. And then work I did with Doctors Without Borders, it was something that I really loved. And there was definitely something that the world needed in doing that. But maybe it was definitely not something I was getting paid for very much. And I was still developing the skill to be good at it. And so shifting to where I'm at now, I'm a chief medical officer for a county health system, so definitely get paid for it. And I'm definitely becoming good at it. I've done leadership skills. And I do other things in life that allow me to meet the pieces of what I love and then things that I feel like that are needed. So just a model to be able to think through. So with that, going back to finishing residency, this is now probably a dated reference, but there was a book series called Choose Your Own Adventure. And as an example, it would be you're running to a cliff and there are bandits who are chasing behind you. Turn to page 4 if you decide to jump off into the ocean. Turn to page 6 if you turn back and fight. Turn to page 10 if you decide to just try to run. And I felt out of residency without true global health trainings that were existing, I was having to choose my own adventure. And so
Just a
I
sec.
leaned
I need
on,
to.
sorry, there's someone might need to mute. Okay. I needed to lean on others to be able to gain some of the skill sets. So a little bit about what happened for me in residency. This is me as a senior, doing night round. My intern there, Mark Applebaum, we were in the old Parnassus building before we moved over to Mission Bay. And I was one of the people that in residency loved every rotation I did. And part of it was I knew that that was the one time I was going to get a real deep sliver of GI or a PMONC or whatever it was, PICU, knowing that if I was going to be working abroad, I wouldn't have all the resources around me. And I really needed to sort of absorb like a sponge everything I could about that specialty, and realizing that for all of us, 95% of what you're going to do in residency will be the last time that you do that deeply, right? You will end up choosing a path, one of the things that you will do more of, and the other things that you will mostly leave behind. And I think that's also something to pay attention to yourself as you go through your own rotations. If there's one that you're really drawn to and really dislike all the other things, that maybe staying in an academic center, staying just in that space is actually what you're going to thrive around. So I didn't have a picture of being a NICU hospice, but I talked about that. One of the key things for me there was I wanted to become really comfortable about resuscitation. So as a pediatrician, if you look at the age spectrum from 0 to 18, the more that you're doing work closer to 0, the more that you have value add. And what I mean by that is teenagers, and especially older teenagers and young adults, the internist can help take care of them. The family medicine people can. In terms of what we add that very few others can is the smaller and smaller that they get, and especially the preemie level care. The other piece was going back to that skills that I wanted to gain was becoming very comfortable at resuscitation, knowing that if you think about value add or benefit, one of the cheapest interventions that can save a life is literally bag masking. That's it. And doing it well and understanding the full NRP and being able to teach people it as well. So I did go on to become an NRP instructor. Just because of all the other busy things in my life, I've let that go at this point, but it's one of the things that I did love. So after doing that for a year and a half, was first married at that point too, and we'll talk about my partner's journey and her own international work. I got to follow my dream and do Doctors Without Borders. So I did spend a year in Zimbabwe. I want to be thoughtful about exploitative pictures. So this was actually done as part of a fundraiser from the hospital itself. There was consent obtained to be able to have this picture. So clinically, it was probably the most rewarding year of my life. I got to do work that was incredibly needed, work that was really complicated, got to work with very few resources. And a lot of these kids were coming in full-blown stage 4 AIDS. So essentially no CD4 count, massive viral load, and lots of opportunistic infections, and really needing to work closely with them and the team there. The individual at the desk there, Takunda, I'm still in touch with, he was on attachment with me, which was the British equivalent of an internship. So learning pediatrics, and that got to actually count toward his certification to become a pediatrician. The book that he's documenting in, that is the medical record. And so it's unlike what we have to do here for those who are physicians of just massive amounts of paragraphs that are copy paste from the previous days, especially on our inpatient, doing things that are actually what matter to the patient. And then the one that's under his left elbow there with the colorful tabs, that is our formulary. That was all the medications that we had. So I looked through that. And then off the table, you can't see, is basically the lab. We drew the blood there while we're there. And then the room right next door is the pharmacy. And so it was pretty simple, straightforward, the work that we got to do there. And I'll talk a little bit more about Doctors Without Borders itself. Due to time, I won't go into all the different pieces about it, but for those who get to hang out with me at the general, I'll go into more of the details. But part of the history of it, its mission statement started with the Biafra crisis. So this is a scene in a part of Nigeria that was basically being cut off from supplies from Lagos, and there was a separatist movement happening there. And so the Biafra region was basically slowly being starved. So these doctors were working with ICRC at the time, International Committee of the Red Cross, and showing up, every few months to care for the people there. And so all these children have severe acute malnutrition, or SAM. And so I'll go right into, why do they have white stickers across their forehead? Anyone want to guess? Some of you may have seen this talk before. So in severe kwashiorkor, having something that is moving across your skin, you might get something called Nikolsky signs that some of us know. So they lose skin integrity. And so the wristband itself, rubbing against what we standardly do, can actually lead to sloughing of the skin and potentially lead to infection. And so putting it on a place where there wouldn't be as much skin movement, the forehead was what some of the best practices around severe acute malnutrition came up with. So that's one little clinical nugget for the day. But the work here, one of the key things, ICRC requires people to sign an oath of silence. Has anyone heard about an oath of silence before? Anyone on here? So the oath of silence meant that you couldn't speak about what conditions you saw there or any of the humanitarian work that you did unless you got express written permission by ICRC. And part of the reason for that in the humanitarian space that they had argued was it allowed them to enter spaces even when they were hostile governments, to say that we are just there to help the people and not get involved politically, and whatever you do, we're just there for the people. What these doctors were feeling was, without the world knowing about what's happening, again, before the internet, before there was other ways, drones or other ways to see what was happening, they were feeling like they were subject to and witness to a genocide or a mass slow killing of a group of people without them being able to tell the world. And so they felt that it was their own moral obligation to be able to tell the world, but knowing the consequences. So what is the consequence of violating this oath of silence? You could potentially have your medical license revoked. So they would actually go straight to the licensing board and say this person violated their own our own rules. And so it was a pretty high offense to do so. But this group felt that what a particular country had for their own rules, so France, their obligation as a physician was higher than what a particular country would want. And they felt that they were not a physician for a particular country or respecting a particular border, but a doctor across the world, hence the name Doctors Without Borders. So they went straight to not just talk about it, they actually created a press conference, which is photographed here, to actually talk about what was happening there and create this organization. And sure enough, ICRC did attempt to have their licenses revoked, to lose their ability to practice medicine in France. But there was such a public outcry and support of what they were doing that they basically backed down. So that's a little bit about the origin story. The three main principles are neutrality, impartiality, and independence. And I'll just share a couple sentences about each of those. So the key driving force is the idea of independence. In assisting populations that are in distress, you need to be able to work wherever you think is what the medical necessity is. So an example here in Northwest Pakistan, the government there asked for MSF to come in to help train up their orthopedic skills. So they were having war injuries or other landmines, and so wanting them to build up the skills there. MSF did their own independent investigation and assessment and came out to find that it was actually perinatal care is what they needed most. So both OB, delivery, and pediatric care. And so they said, we can come into your country, but that's what we would do first. Once that is stabilized, we would potentially work with you on the orthopedics. So to have the audacity to stand up to a government that way and to say, nope, we're not going to do this. This is what we'll do. You need to become financially independent to be able to do that. And so this is them setting up those hospitals, setting up the maternity units. And then later they did actually do the orthopedic care, which you'll see in another picture. So how do you stay independent? This is now getting a little bit into the nonprofit humanitarian space. You need to become financially independent, not have strings attached to hospital governments or receive them from the local institutions themselves. So the vast majority of the funding, as you can see here, is independent. So yourself, myself, people who give $5, $10, whatever, some corporations and foundations who usually don't have ties. And really the only public institutions or governments are things that are cross organizations. So Switzerland as an example, or foundations or organizations such as UNICEF. So knowing about MSF, one of the concerns I had was they don't share necessarily all the good that they do. In other words, there wasn't really published best practices. MSF was sort of known as a doesn't play well with others type organization. But while I was in residency, really a landmark study came out that really changed their perception and changed the future of humanitarian medicine in that space. And it was around HIV care. And so HIV in the early 2000s was still really only, the AZT and the medications really only available to the West. That it wasn't widespread availability of AZT and the other drugs that were being developed in the places where people actually have the highest prevalence of HIV, which was going to be sub-Saharan Africa. And part of the really, I think, racist and anti-global South prejudice was these people can't take medications long-term. They are not suited for that. Their infrastructure isn't suited for that. And these countries and these individuals aren't going to, so we can't do it. So MSF said, okay, hold my beer. They made a 12-country study across 10,000 children under the age of 5 over 3 years, and actually showed that if anything, their survival rates were exceeding those that were happening in other countries. So survival rate at 1 year was 93%, and at 3 years was 90%. Remaining in care at the same institution at 3 years was 75% retention. And for people who are anywhere close to graduating residency, if you have 75% of your first year patients in your primary care continuity clinic still with you at the end, you are a hero. These are people who are spending sometimes multiple weeks worth of their income to travel to these clinics and taking hours, and they still remained in care. And so it did show that antiretroviral treatment was effective and was something that these populations could have. And so it actually really changed the game for the Global Fund for HIV, TB, and malaria, and helped increase a lot of the funding. And this was the beginning of one of the many other studies that their epidemiological center called Epicent, that's listed here as the first location that the work was done, was able to show that this work was cost effective. So signed up for them, and where did I end up? So Zimbabwe, a little bit for the geography for us, a little on the bottom right here, Zimbabwe is landlocked and is part of SADC, SADC, so the Southern African Democratic Coalition. So all the countries down there, you have one particular travel pass that allows them to move between each other, similar to Europe, getting like the Euro card, even though people have their own nationalities. And so getting a long-term resident visa, since I was there for a year, I got to actually travel among these countries that were down here. One little political geography piece, if you drew a line from the top left to the bottom right through the country, you have very different climates. So the Mashonaland West at the top central, Mashonaland Central and East are more lush, tropical, full of like rain, and so have a lot more produce that's there. Not surprising, Harare is the capital, is in the center of that. So, and the people there are called the Shona, whereas on the to the left, to the west side, closer to the South African and Botswana border, it is more of a desert, arid-like country. And you actually have one of the driest deserts in the world in Botswana, the Kalahari Desert, extends into the Matabele land north and Matabele land south. And the place where I was in was Bulawayo. So Bulawayo is right on the border between the two, and it has a little airplane logo there. So it is the second largest city in Zimbabwe, with a population of 1 million. And part of the reason that Bulawayo had MSF there was HIV care, similar to what was happening in Nigeria that started MSF. There was a cutting off of supplies to Bulawayo. And part of the reason was ethnic differences. So the Shona, who was in power, Robert Mugabe, which some of you may have heard the name, was a dictator in Zimbabwe from its founding as a nation in 1980, formerly called Rhodesia. And yes, Rhodes as in Rhodes Scholar, until I think it was just now, we're at 6 years ago. He didn't really allow for HIV care to enter into Bulawayo in the same way. And so MSF declared it an emergency and was there. By the time I was there was a power sharing. The vice president was Ndebele. And so there was starting to be more organizations coming in. So I got to be there for the closing project. So what were some of the skills that I needed to gain while I was there? One of the big ones was malnutrition. So in any of the work that you do abroad, and especially in resource restricted settings, understanding a bit more about malnutrition is a really key aspect of being able to deliver care in pediatrics. And so I had to learn quite a bit. So I'll do a little bit of a, what is this happy little child holding on to? What are they eating in this picture? Anyone? You can either put it in the chat or unmute and tell me if anyone knows what these are. So it's the white red satchel. So it is the category is an RUTF, a ready-to-use therapeutic food. And also the particular brand, I think this one was Plumpy Nut. So this is something that was a game changer in malnutrition treatment, something I got to learn about once I was there. So malnutrition was being treated with NG feeds for severe acute malnutrition for decades. And UNICEF, along with MSF and a few other alphabet soup organizations, came together to develop something that could be shelf stable, that could be palatable to local communities, that could have the full range of macronutrients and micronutrients, and could potentially persist for years. And it really changed the game. And so learning about that, and learning the ratio of BMI percentage for the child to the number of packets that they would need, understanding how to do it from newborns all the way up, was one of the things I got to gain there. One of the other fascinating things was there is an online severe acute malnutrition course that you can take through the WHO. And one fascinating thing was the cost of taking that course was tied to your IP address. So if you were in the global West, so in the US or in Europe, it would be, $1,000 to $3,000 for the course. If you're in a middle income country, such as India or Brazil, it would be about $100. And if you're in a low income country, such as where I was in Zimbabwe, it was essentially free, which I thought was also a fascinating way of being able to allow resources and knowledge to be accessible everywhere. So it was one of the things that I got to learn about while I was there and had to help actually run our malnutrition center. One of the other things is learning about the food politics, which is its own fascinating, could be an entire talk in of itself. So one not so bright stat or fun fact is I learned from World Vision and World Food Program, who this box is labeled there in this picture about the politics of the food that's brought over. What percentage of cost in the total budget for World Food Program is just transporting the food? I want to give guesses. Maybe I'll do with a show of hands of numbers. So if you think it's 20%, put up a 2. If you think it's 30%, put up a 3. If you think it's 50%, put up a 5. Some numbers. So in some regions, it's as much as 50% of the cost. On average, across all their programs, about 30% of all the cost is just transport. So rather, and part of it is because their contracts are tied to basically Iowa farmers having soybeans come from Iowa or from the middle of our country to be able to actually have the aid rather than actually develop the ability to grow this produce in Africa. So lots of different places that you can insert yourself to make change that will actually create dramatic impact in the world. But got to learn a lot about that. I'll share one of the pieces that was actually quite illuminating to me too. So there wasn't, and it's shifting now in these places, but there wasn't quick start AIDS treatment then. So what that means, what we have currently now, actually, just had a teen at the General last week who was diagnosed with HIV. As soon as people are diagnosed, you begin treatment, is our current standard practice. That was not the case here because of resistance. So if you start on medications, some of you may know, HIV medications, and you stop it and restart, you can develop resistance, just like we develop resistance to antibiotics, or as we all learned during COVID times, strains change or mutate based on other types of pressures. And so we instituted at the time that the individuals had to have 4 sessions of counseling and learning about HIV, all the things that were stigmatized or any misinformation about the disease, and learning about what to do about the medications, what side effects there were before they could even begin. So they completed 4 sessions. And one of the things to me that was really heartening is the type of people who went into doing this. So this individual here just inside the door, so the teenager on the right there is newly diagnosed with HIV, and she's learning about the HIV medication and diagnosis. And the individual that's counseling her, Sebonge, became one of my closest colleagues there at MSF. She was actually vice president of a bank in Harare, so a really high level, especially for a woman in a country that still had a decent amount of misogyny, and so had major achievements. But she was seeing her own nieces basically become orphans because her sisters both died of AIDS, and realized like what's the purpose in life of making wealth and having status if we're not helping the next generation. So she gave up all that to volunteer with us to be a counselor. And so used her amazing, finance and other leadership skills to help restructure how we did this. But she was one of many people who were committed to help what was an existential crisis for the nation. Just to give the numbers to put in perspective, the highest prevalence group was women of childbearing age. And so 18 to 30-year-old women had as much as 25% were HIV positive at this time and in this place. So it would be, among the highest levels, would be the equivalent of obesity or diabetes in our own country. So this was a true crisis. This is another one, Tokunda, who was a teacher. And actually, he was a principal who left because he was also seeing his kids lose their parents and thought that this was far more of a more powerful way to invest his time. And so this was the transition time. So you can see Takunda was wearing an MSF jacket. And by the last month we were there, we were handing it over to the Ministry of Health. So we had the Ministry of Health staff take over as we were departing. Very long lines to come see us because we were the one place that people could come. But part of what we were doing was decentralizing the work. So we were training up other clinics in more rural areas to also be able to have the HIV protocols. Another powerful one was a teen resource center, knowing the power of peers for teens, right, for anything that they want to do. So any teen who was getting started on HIV care got paired with one of these trained peer counselors. And so they would be able to, share similar life journeys and challenges that they had around the diagnosis, the stigma, how to talk about it, and then the side effects, taking the medication, and just having this support group. So UNICEF helped fund this resource center where they got to have some educational stuff there, but it was also really just a place for them to come together to hang out. One of the other things I thought was powerful was given, again, the scale and how many people were affected by HIV. And again, as the medications were just entering into the country, about 60% of them were single orphan, meaning they at least had lost one parent, and about 30% were double orphan, meaning both parents had died. And so that level of destabilization of your life, of the complete dissolution of your family. So it's not just their parents and parents, it's their aunts, their grandparents, everyone around them, having each other and having a different community to support in a place where there wasn't a really robust foster care system because it was just such a large scale. one of the beautiful things was in Zimbabwe and in the Ndebele language, there's a big piece of oral history. So passing on stories and journeys through song and through story. And they were, there had been a lot of songs around TB and malaria and these diseases that had been around for a long time, but there hadn't been any around HIV and AIDS. So they were literally writing and creating the first song. So this is them in circle doing some of that work there. And they got to actually be on an album called The Positive Generation that Adele and a few other musicians were on, who actually traveled there while we were there, which was pretty amazing to get to be a part of. And that was a fundraising album. The other groups who were truly heroes, I think, is the mothers who would go around. And again, this is a place, even though it was 25% prevalent, there was a lot of stigma around HIV. And with the misogyny and the level of power that men held, women had to ask for permission culturally to be able to go and speak about these things. And most of them were not actually granted the permission, but they still wanted to go anyway. And there was the double whammy of stigma for that woman in the center. Pufulu. Pufulu had an albino child. In Zimbabwe, and unfortunately a lot of countries in the region, the thoughts are children who have albinism, there's either witchcraft or that they're possessed or other things that come up. And so she would bring her child to show not only was her prevention of mother-child transmission successful. So all these women here, because they were on treatment, they did not pass it on to their child, even though they were breastfeeding at the time. And so they were promoting that program, which we had a 99% success rate in this region, but to also show that her child is healthy and beautiful and should be included. One of the other important things that I got to do there a lot is teaching. So this is me at the laptop here doing one of our multiple 3-day trainings. And it would be everyone from leads of pharmacy to principals to actual nurses, physicians, some other government officials, government workers. And we would go everything from the actual pharmacology of NNRTIs, non-nucleoside reverse transcriptase inhibitors, all the way up to you have a depressed 16-year-old who they've lost their parent and think life isn't worth it and want to stop their medications. How do you counsel them? And so the entire spectrum would get covered in these multi-day trainings. And it was really powerful to hear their own testimonies, their own stories, and be able to actually give back in some way. So all those grand rounds, experiences that I got exposed to helped me kind of set the course for the type of teaching that I got to do there. And then the next level one is getting to go to like national conferences. So this is a little team building exercise in the evening at ZIMA. So ZIMA is the Zimbabwe Medical Association, which sounds way cooler than the AMA. And those are my two fellow Doctors Without Borders physicians who were at the other project site. So Nuria, right next to me, was I think she was an internist who was working in one of the smaller projects close to Botswana, and then Mohammed Abdul Rahman was a Sudanese physician who was a family med physician working at the border with South Africa, and they been able to stay in touch with them, and both of them continued to work with MSF for quite a while, and those relationships were really powerful. And again, we have team building exercises just like a lot of other organizations do. And so these are all my MSF staff. So everyone from our cook to our drivers, our janitor, our pharmacist, our logistics staff. And one of the things that I like to call out here is it helped me in my own journey around my own internalized racism or prejudices that I may have had. So understanding the political history of Zimbabwe, that every place in the world has its own way of ranking people. They didn't have slavery in the same sense that we've had in our country, but they did have ranking of people by their different cultures, their different languages. So it helped me be able to come back with a different lens around our own history here in America that doesn't have to be this way, and be able to speak about race in a way that feels more authentic and more open. And for myself, when I went there, I kind of thought everyone sounded the same or spoke the same, but then as I got to be there longer, I got to see the nuances or differences. And I think the analogy I use is if you've been in the dark for a while, or people in solitary, and you step out into the sunlight, it takes your eyes a little while to adjust. It took me some time to adjust to the nuances or differences among the people I got to know. And then by the end, probably became closer to these individual people than I probably was in any other workspace I was in. Maybe my co-residents in residency who you spend lots and lots of time with. But even then, you don't live in the exact same places as I did with all these people here. So really grateful for my time there. So one of the key things I like this slide here, if you do want to do MSF, what is the type of work they look for is people who are really, really flexible, because especially the work that's going to be in disaster zones or places where there are war, you might literally have to evacuate and move to a completely different project from one day to the next, or things are moving so quickly that you may be thinking you're showing up for a malaria project and you're actually going to be shifting to do a cholera project because there's a cholera outbreak, and have to completely change the type of care you're providing. It may be something where there is 2 or 3 experts who are going to be around you, and they all get pulled to go somewhere else, and so you literally have to become the expert within a course of a week on whatever the condition is that they were treating there. So knowing yourself and your own comfort level and being honest if that's something that you could do. One of the things that kind of led me to the path of entering into leadership that I'm in now is understanding the scale of all the both diplomacy and administrative work that is behind making dramatic change. So for the work we were doing there, I got invited to present at that national conference you saw when we were, the picture I had with the other 2 doctors. And what we were trying to do was shift how HIV care was being provided in that region of the country. And so rather than everyone come to that one really busy clinic where you saw that long waiting line of people, we wanted to simplify the protocols so anyone could do it. We wanted to decentralize it. So instead of in that main hub that we had 4 outlying clinics that were about an hour away in every direction that could take on HIV care, and then integrate it into primary care. And just to give an analogy of where they were at, they were still sending all kids who were initiating antiretroviral treatments to specialty care and allowing them to stay on there for a year. It would be like if every diabetic in our country who got diagnosed with diabetes was sent to an endocrinologist to actually get care. It's just unsustainable, right? It's something that was so widespread, but that they were still in that system. So it was part of the work we were doing, acknowledging as the outsider, as to their eyes, the white person who was coming to tell them that that's what we need to do clearly wasn't accepted in the same way. And so we did partner with others who were Zimbabwean physicians themselves to be able to help really take on this work and to take it to the next level. But it did get me to realize that I'm interested in working in administration, working in the leadership level to not only make the change patient to patient, but the actual systems of change itself. So now I talked about how amazing my work was there, how much I loved it. Why am I still not in MSF? Why am I still not doing that work? Here's sort of the elephant in the room. There's this thing called student debt that we all have. Many of the other physicians I worked with were from countries where going to medical school is either free or very nominal in cost because they want people to do public service. Here we didn't have that. So I, at that point, had, going back to the choose your own adventure, a decision tree. Do I go back to America and just do the work here, or do I try to find something different? So thankfully, I did stay in touch with one of my co-residents, who some of you may be in touch with, Chris Carpenter. He was a resident the year before me, and he was working in a small little spec called Saipan. And so Saipan is part of the United States, the Commonwealth of the Northern Mariana Islands, and they, as a U.S. protectorate, have Medi-Cal. And so because they have Medi-Cal, they also allow for National Health Service Corps loan repayment. And so though they can't pay the same salary as the US level, it allowed me to actually do some of that work. And so I went first as a locum stint. So that means just a short 2 to 3 month time period. And my partner at the time was doing human rights law. And so I just emailed them and asked, do they have lawyer jobs? And they're like, yeah, we have a shit ton of lawyer jobs for some reason. So she was able to find a job there. And so we went, and this is my 2nd week in Saipan. I met someone who was developing his underwater photography portfolio. You can kind of see it scroll down the bottom left, Mike Ronija, which is not his real name. That's the name of the region. That's his photography name. It is a major dive destination. Those are called sea fans that were around me that literally are moving around like fans. So kind of an amazing place. So it went from a landlocked country in sub-Saharan Africa to here on the other side of the world. And this is their actual marketing slides that they send. And those are actual pictures without filters of how it looks in Saipan. And just to give you a sense of the geography of it, if you drew a line from Japan to New Zealand, it's exactly halfway. So it's one time zone ahead of Japan. And so we form the western edge of the Pacific Ocean. So the water in between there is called the Philippine Sea. And it's a very hotly disputed area with China and others for militaristic reasons. And part of the reason we are there was World War II. It was formerly a Japanese colony, hence the name Japan and Saipan sounding similar. And we remain there really for, if Korea decides to act up or anybody else, we already have some bases in the area, those types of things. So in terms of the actual life there, so there's 15 islands right alongside the Mariana Trench, which some people may have heard of, the deepest point on the earth. It's just to the east of there, probably right where the word ocean is, where it says North Pacific Ocean. And that's a place where the entire Mount Everest could fit into the water upside down. And so of those 15 islands, there's only 3 that are continually inhabited, and they are Saipan, Tinian, and Rota. And one other not so fun fact historically is that Tinian is where the atomic bombs took off from. And so you can still actually see those sites. And there's something that, it's deeply moving in a very different way, kind of a dark way of our history to be able to see those places. So we in Saipan were actually the referral hospital for some of the ones in that region. And Guam, which is a territory in that same chain of islands at the very south, was a place where we would send some people depending on the care there. So 14 total islands, super small, 184 square miles across all 14 islands is basically the size of the Bay Area. Those are all the languages there. It is U.S. There is the dollar. The Chamorro are the ethnic group who were there originally, and the Carolinians are the next island group that were south of there, who, when they married, their children would be called Chamolinian, which I thought was pretty awesome. It has some similar Polynesian, Micronesian culture, but it was a pretty fascinating place to be. Knowing where with time, actually, I won't be able to get to the case here. So I'm going to actually forward through this one. Unfortunately, if you work with me, you'll get to see the case itself. So we did do transport everywhere. So in the middle of an ocean, you can't just ask for the ambulance to come and pick them up. You have to get them on a plane. And in some cases, if the child is large or needs to be in a gurney, this is how we take them in a car seat for newborns, or if they're smaller, and just have them right next to you. Sometimes in this case, I was bag masking a child who actually had a recurrence of a tumor at the brainstem and actually caused them to become paralyzed suddenly. And so they needed to be evacuated somewhere where they could get oncological care. And so we had to take them in a helicopter, at least to the next island over. And then you get to fly over these uninhabited islands, which was pretty beautiful. As long as you make sure one person is bag masking and the other one gets to look outside, you get to have a mix of that. And then we flew on commercial flights. So this is a United flight, and they would just put in a curtain and allow us to care for this child to get them to where they needed to go. I also got to do primary care at the same time, which was kind of great, doing the full spectrum, and just super adorable kids that I got to see and get to know around the island. So I got to see this little one from being at the delivery through their first 2 years of life. And then, like you do here, you have your frequent flyers in your hospital. So this was a kiddo with Down syndrome who had an ASD that for lots of logistical reasons, the mom couldn't get off island to get it repaired. And so would get a, flu or some type of cold, and it would flare up into a pneumonia. So need to be admitted most of the winters, even in hot places, you have those seasonal things. So got to know him quite well. And fascinating dermatological things that you have to figure out what to do on your own. So one of the contraindications to back to sleep advice is having an open wound that is coming out of your central nervous system. So this was a child who also, for lots of logistical reasons, passport and otherwise, couldn't get off island to get this repaired. So we were having to every now and then admit it and deal with wound care here. Pass time-wise on some of the fascinating derm things I have here to allow us some time to ask questions. We're going to 11:30, is that right?
Yeah, we have 10 minutes.
Okay, all right. So I will pass on the derm stuff, even though I love dermatological conditions. You guys will just have to wait until you get to talk with me at another time. So acknowledgements, thanking the folks there, allowed me to have their pictures, all the people who taught me, the full teams of people who taught me. Some folks who are still connected to UCSF, Tim Kelly and Glenn, and then the residents who were there before me who told me about it and got me to come. This was my final continuity clinic day at the General. I was in Thursday pod for those who are around. I don't know if maybe Naomi Bardak would be the only person on this picture who people would know. Maybe some others are still around in different ways, but yeah, just pass through this one. This is my last sign out. Jokingly, everyone there was signing out to me at the same time. This is back in Parnassus when we had bunk beds. So the intern actually literally slept on the bottom and the senior slept on top. And some of these people are still around. Jim Bayer to my right is a GI doc, and I think Amit is a hemonc physician.
Yeah, he is.
To my left. Yeah, so you guys might recognize them. I think the others went into practice other places. And my last team, who actually, yeah, both of those people to my right, you would know as their senior. So Holly and Rachel, who you guys probably also know, who are around. Diana went into OB. All right, and with that, I will end. Oh, this is the one PEDS resident, the last PEDS resident who came to Saipan while I was there. I restarted the rotation when I was living out there. And I won't get to have the talk about HEAL initiative, but look up the HEAL initiative. You'll learn more about it from some others, but that's the way I still stay connected to all the global health work. So with that, I will stop sharing and I'll hand it over to Teresa. I don't know, to facilitate Q&A.
Yeah. Great. Yeah, we'll start with the Barbara's question in the chat, and then others feel free to either come off mute after that or put your questions in the chat. So Barbara asks, what are your thoughts on the advantages of doing a global health fellowship versus doing like an ER fellowship and then working in a global setting?
I think it depends on your own comfort level and what, again, going back to that skill set piece, like how much hands-on do you want to be able to do? I know some people who either work in domestic places that they were going to do some ER stuff, like working in Navajo Nation or in other locations where as a pediatrician, you would actually rotate in the ED itself. You still get to do work that feels of substance for you. You get paid, you get to be in a place where the needs are truly high. Other people do go on to do an ED fellowship. I think some of you might know Jean Jr. Or Jean Jr. I'm not sure if she pronounces her first name. She was an alum from, I think, 4 or 5 years ago. She spoke at the retreat a few years ago. She decided to do an EM fellowship. She went to Boston and did MSF work as well. And I think she actually splits her time between MSF work and actually working in a Indian reservation domestically. So sorry, you kind of have to know yourself, but think about what skill sets you're going to gain from it and think about your career afterwards when you want to come back. Do you want to do primarily ER work? Because it is becoming, as there is more and more EM fellowships, it is harder to do PEDS-EM domestically, again, depending on where you live, unless you've had EM trained, but that could be part of, I think, the decision tree. And with that, open up the questions. And if you can, if you're going to ask a question, tell me kind of what stage in the training you are from pre-med to attending, and maybe go ahead and ask your question. Or comments, if you have comments about the talk too, open to that.
If you allow me, hi. May I?
Hi. Hello.
Hi.
Yes.
I'm a GI fellow at pediatric gastroenterologist fellow at UCSF. I was wondering if there's any opportunity to work while working in the US at any institution to work globally at the same time, getting paid for it. Like, work globally at the same time, still getting paid for it. Isn't it like 2 weeks or a month, a year? In an institution that allow you to move in between international and domestic.
Yeah. So I think there's a lot of different models for that, and it's always changing. When the chair of a department who set that up leaves and someone else comes in, they have a different vision of what they want to do. Those things might fade away. So I can't say that there's an active list right now. It sometimes is a recruitment piece. And I would say the more and more that people such as yourself, when you're going into being an attending, ask for that, those things will come up in the same way that a few years ago, schools started having, sustainability report cards that started coming out. Schools, based on their climate impact, were being rated schools based on their level of being anti-racist or being rated. I think having that being a question that's important for you. The other thing I would say is you being able to negotiate that up front. Like when I first came back to the US, I worked 0.8 FTE. So instead of 1.0, and I knew I was going to be giving up the pay, but that 0.2 FTE I would turn into, 20% of my time in the year. So that ended up being whatever it was, like 10 weeks a year that I could be left free to be able to do that, knowing they probably weren't going to be able to fund it. That said, the further you go up in a career, the more they need you. They might be able, that's a negotiating piece. There are some very unique ones. I remember there was a group of 5 physicians in a practice in Santa Cruz that each of them had the equivalent of 2 months off a year that they would cover for each other. And so some of them did global health work. One of them was in a band, so they would go touring for those 2 months. Others, their children went on an RV trip somewhere. So they each had different pieces, finding people who would help support you to do what you want, even if they don't necessarily do it for that same purpose. And that is a way that people can stay connected to some piece. But great question.
Also in the chat,
Yeah.
so I'm nearing
Sure.
retirement and looking for work after. I cannot travel, so wondering if there are global health offerings that can be done remotely.
Yeah. So I mean, it's one of the things we talk about. COVID was among the worst things that can happen to humanity, and it also gave us an incredible amount of ingenuity. So all the telehealth things that started coming out that didn't exist before. So being able to be a telehealth consultant, either for direct care or in teaching, being able to offer services, be able to offer consultation to groups. Another thing is writing guidelines. So there are places who, if you are a person who is savvy and wanting to keep up with the latest research in a particular disease condition or age group and want to write guidelines for groups, that's definitely something you can do remotely, and you can help make an impact and change that. There's work, people are doing technology improvement pieces. So being able to work on, and I don't know is Josh Bress still someone who gives talks, Teresa? So you might get to hear his work that he does as well. One of my good friends, actually one of the trips in the summer, our kids were in Yosemite together. So that's a place where you could help develop protocols that they have at the bedside there, but help develop it and work on it remotely. But lots of places that you can do that.
As a follow-up, my institution does not do global care except for resident rotation. Do you know how one could get engaged in remote telehealth consultations?
I mean, I just thought of that as an idea here. Again, those things are shifting constantly. I think right now I don't know anything that does exist off the top of my head. If I do think of any, I can try to forward them on to Teresa or Tiffany to share with the group. But I'd say just start networking, talking to others, reaching out to different organizations, and finding ways to be able to make that happen.
We've also put a link in the chat for a very short survey for your feedback. We really value what you think of these sessions and update things every year based on what you say. So please click on that. That was shared by Tiffany. And then Barbara had a couple extra additional ideas that are really thoughtful too. So also refugee clinics and underserved areas, especially along the southern border, are also good options to stay involved. And then Caleb writes, love seeing how creative the resolutions for adherence were in Zimbabwe, and curious about what you've been able to bring from those experiences to your current work.
Yeah, I think so. I am the executive and in charge of our equity initiatives here. And I think it is being able to speak to the biases that we might have about what our patients are capable of doing, what level of adherence they have, or how we also make things accessible. I think it has shaped my ability to advocate for and think through this work. Also the lead of our social determinants of health work that we have here to understand the impacts of transport and impacts of language barriers for our patients, let alone food and housing and all the other things that we know that COVID unveiled for us. It made me become incredibly flexible, of the different types of cultures, the way people communicate, the way people prioritize different things. Understanding that the people that you work with when you're a leader, your own families that you will care for, will have different priorities that are important to them, and being able to enter that space in a non-judgmental way was one of the things I gained that I'll always have with me after doing that work.
And then we'll close out with another great suggestion from Barbara. The AAP section on global health division also has volunteer opportunities, and most require some degree of commitment, 3 months, she says, and lots of trips and opportunities to participate as well.
And I'm not sure if my contact info is available. I'll give you all my personal email address, which I didn't get to say my ethnic background, which is a pretty memorable email. So you can just reach out to me personally. That's I created when I was a teenager. It's probably not surprising, but I still have that email address.
It could have been a lot worse, I'm sure. Oh, thanks so much.
Yeah.
It's such a pleasure to have you, and really appreciate your insights, and hearing your story is just amazing. Thank you.
Yeah, and I'll just close with saying you all are going to choose your own journey in your life. Just embrace what's in front of you. Again, strategic opportunists, find things that feel exciting for you, and know that you'll have a way to make impacts whatever way you do. And if you do stay here, one of the things, if you have the income, you have the ability to pay for others to go do work like donations to Doctors Without Borders. We all have our ways of impacting the work around us. So welcome to the profession of medicine. For those of you just starting, I'm excited to have you all. Welcome to the global health work. So have a good rest of your day. Good to be with you all today.
Thank you so much.